Hello, everyone, and welcome to today's webinar, sponsored by the Northwest ATTC, the Pacific Southwest ATTC, and the Western States node of the NINA Clinical Trials Network. I'm Riley Vest, and I'm your host for today. We are very excited to have Dr. Keith Humphreys from Stanford University here to talk to us today about the landscape of mutual help groups. A couple of quick housekeeping things. First, if you have any questions for Dr. Humphreys during the presentation, please go ahead and type those into the chat box at any time. And after he's done speaking, I'll go ahead and read those to him so that he may answer them. You'll also be getting an email at the end of today's webinar that has a link to a survey in it. We ask that you please take that survey as it helps us make sure we continue to bring content that you're interested in. That email will also have a link to download the slides from today and a link to the Northwest ATTC website where you'll be able to find a recording of the webinar later this week. Additionally, when you registered for today's session, you marked the type of CE or CME credits you are interested in. For CME credits, you'll receive an email with instructions on how to log into the Stanford CME portal, as well as some other instructions. This slide just has some information about the CME accreditation. If you selected one of the types of CE credits, you'll receive an email shortly after the session with instructions on how to receive those. And all of this information is in the slide, so there's no need to write anything down right now. Those of you who requested a certificate of attendance, you'll receive that automatically via email in about a week. Okay, so now on to the webinar. Today's speaker is Dr. Keith Humphreys. Dr. Humphreys is the Esther Ting Memorial Professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. He is also a Senior Research Career Scientist at the VA Health Services Research Center in Palo Alto and an Honorary Professor of Psychiatry at the Institute of Psychiatry, King's College, London. His research addresses the prevention and treatment of addictive disorders, the formation of public policy, and the extent to which subjects in medical research differ from patients seen in everyday clinical practice. Welcome, Dr. Humphreys.
Thank you, Riley. Thank you, Meg. Thank you, everybody at the ATTCs for putting this event together. And some attendees are members of our Clinical Trials Network. I want to specifically thank you for being engaged in this important effort that NIDA does to help us understand ways to improve the quality of treatment for addiction in our country. I'm going to talk today about, actually not going to talk about professional treatment, I'm going to talk about something else, which is mutual help groups as an addiction recovery resource. I first heard about these 35 years ago, it's hard to believe. My first job in the field was 35 years ago. And I worked on a project in the state of Michigan where we would meet people, it was a research project, we would meet people when they came into the public treatment system, interview them, see how they were doing, you know, how's your substance use, how's your housing, how's your work, how's your health, gave them addiction severity index, that kind of stuff, and follow them up 6 and 12 months later. I'd never worked on an addiction project before. I didn't know anything about addiction, but it paid better than Wendy's, and that's actually why I took the job. And the assessors on the team were interesting. There were two who interested me because they seemed to have some little code they spoke to each other. You know, say like, you know, let's get some gratitude in our attitude, take it one day at a time. I didn't know what they were talking about. But one day we were all having lunch. We were in Detroit, and we happened to all be locating clients at the same time. So we sat together, and the two of them, and we're just going, in my view, just going, you know, crazy with this language of don't take my inventory, easy does it. And so I finally had to ask, are you two Freemasons or something like that? And they said, no, we're not Freemasons. And I said, why do you talk that way? Are you, CIA operatives or whatever? And they said, no, we're in Alcoholics Anonymous. We're in AA. We're in AA. And then they said, you know what AA is, right? And, you know, wanting to be cool, I said, oh, yeah. You all came out and jumped my car battery last winter when it was dead. Great organization. Appreciate it. They said, no, not that. AA stands for Alcoholics Anonymous. And I said, I never heard of that. What is it? He said, well, we, two of us are, we're in recovery, and we meet in these groups, and we share our experience, strength, and hope, and help each other live a better life. And I said, well, so who runs these groups? Is it psychiatrists or social workers or psychologists? And he said, no, we run them ourselves. And I said, so you just do this and you think you're going to get better that way? And I go, oh, yeah. So with the humility and open-mindedness for which young men are famous, what I thought was, wow, Does that sound stupid? I mean, it sounded incredibly stupid to me. You got your folky little expressions, you're going to sit around without any professional help and you think you're going to recover from a terrible illness. That sounds really crazy to me. I didn't say that. That's what I thought. And fortunately for me, I had not progressed so far in my education that I was completely incapable of learning. So I took the invitation when they asked me to visit an open meeting with them. And I started looking at data about these groups and actually did my master's thesis about these groups. And I realized that I was wrong, that I had really underestimated the power of this resource in a sort of snobbish professional way, didn't appreciate what people could do for each other. And I think the whole field has been through the same process. I mean, my views at the time were normative. I mean, all the professors I was around also looked down on AA. And, you know, the next 35 years, due to a lot of people's hard work, has been a re-education. And so in that sense, it's a positive story about recovery, but it's also a positive story about science, that it should help us overcome our prejudices, which I certainly had as a time. So that's the background of how I got interested in this phenomena. And I'm going to walk you through some of that science today, done by, as I said, lots of different people. I'm only one of many, many people who have studied these organizations, but tell you a bit about what science knows at this point, and then what it might matter for doing a better job helping people find recovery. Okay, there we go. So in terms of disclosures, we're not going to be talking about any for-profit products today, so I don't think there's any disclosures. I could tell you I bought a lot of stock in Alcoholics Anonymous, but that's not true. So there's no conflicts to worry about today. So one of the things I learned as I started to read more about these groups is that it's interesting how all over the world there are mutual help associations. They're different in terms of their orientation and where they come from. For example, Blue Cross groups in Austria emerged from the church. Via Libre in France emerged from unions and workers' movements. SARDA in Hong Kong came out of were people who had formerly been treated and wanted to form an alumni association. But it's sort of an interesting thing about the condition that seems all over the world, whether they knew about AA and NA or not, people have come to the independent conclusion that there is something potentially healing about gathering with other people who experience the same thing. And I take that as a form of wisdom because people do want to get better. And that clearly the people who founded AA, the most famous of these groups, understood that. If you want to read about this, I actually wrote a book about it, which is down at the bottom, Circles of Recovery, which I think you can probably find for about $10 online, or unless it's an autographed copy, those usually go for about $5. Okay, so let's go to AA, which is the prototypic one, the one most noted. A lot of you will know this, so I apologize for repeating for those who do, but I'll just tell you a bit about it. It was started in Akron, Ohio. You can go there. I actually went there, gave a talk at the Psychology History Center there, and looked at the house of one of the founders who's there in the 1930s. This is a time when nobody wanted to treat what was called alcoholism, and they were completely rejected by the healthcare system and pretty much by everyone else. And it was a desperate spot to be in. But two people met, now known as Bill Wilson and Dr. Robert Smith, and discovered that when they talked to each other, the desire to drink left them, that it helped them become sober in a way that it didn't when they talked to many, many other people, and when many other people nagged them or criticized them or punished them for the behavior. But there was something special about that human connection between two people as peers talking honestly about their condition. And that is the basis for that was the first AA meeting when the two of them met, and it spread quite rapidly after that point, bringing more and more people in. They decided that the organization's sole purpose was to help people become sober. So it was not to make money. It was not to instill a particular viewpoint. It was not to advocate politically. It was instead just the primary purpose, which is to help people become sober. And by sober, they don't just mean not drinking anymore, although they certainly do want people to abstain forever. But sober also meant a different lifestyle, a different outlook, a spiritual reconfiguration, a life centered on service to others, a life free of self-centeredness, a life of honesty. And that's what they were hoping to instill. As I mentioned, the organization has grown pretty dramatically. By 1950, it had about 50,000 members, and it grew very fast after that point. And worldwide, there's probably, although AA's official count is about 2 million, 1 or 2 million people worldwide, it's probably, actually not probably, it is, that's an undercount. It's probably more like 5 or 6 million around the world. And they offer different things, these groups. There are meetings, where you could come in and people gather and support each other, and there's different forms of that. Sometimes it's a meeting where there's a single speaker who talks about his or her story, and other meetings have a topic that they discuss together. Some meetings are what are called first step meetings, particularly any meeting that has a newcomer, where they will focus on what the early part of recovery is like. And these are all over the place, and I think we all know that. And you can find them virtually every community in the US and also in many, many other countries. At least 180 countries have these groups. It also has sponsorship. Sponsorship is something a little like a peer recovery coach, not exactly like it, but sort of a little like it. That's where somebody who is further along, like say, they've been sober 3, 4, 5, 6, 7 years, help somebody who's just starting out go through the recovery process. And the logic of AA was that actually the sponsor benefits from this arrangement just as much as the sponsee does. The fact of selflessly giving of yourself is good for staying in recovery. And by the way, there's a lot of evidence this is in fact true. It's one of the interesting findings of the social support literature. Giving support is as helpful to us, at least, as getting support. AA also has a lot of literature, books that, the most famous one is called The Big Book, which was big because it was printed on really cheap paper in the 30s, pulp paper, which is filled with stories of members. But it has 12 steps and 12 traditions, there's meditation books, there's many others. And it has 12 steps, which I think people know, which are a recommended pathway to recovery, not mandated. In fact, in the Big Book, they say the 12 steps are but suggestions. But if you look at them, one thing's interesting is only one of them even addresses alcohol, and the rest are about this broader process of attaining sobriety. AA has a disease model. They call what they called alcoholism a disease. But they didn't mean disease the way NIDA does. They weren't saying it's a brain disease in a strictly biomedical sense. They saw it as a condition of involving the body, certainly, but also the spirit and one's psychology. And they actually almost used the word malady instead of disease because they didn't really want to say that they thought this was merely like cancer or something like that, but they realized nobody knew the word malady anymore. So they kept with the word disease, but it's a spiritual disease is the way they see it. I mentioned the growth of it. It's had a huge influence on those of us who are professionals, certainly in terms of, if you look at the content of treatment in many different countries, you can see a lot of influence of 12-step. There have been at times people involved in AA and NA who have been important policymakers who have shaped how treatment is created. And it is the number one sought source of help in our country for alcohol. In other words, if you ask Americans, and studies like Ron Kessler have done, if someone's leaving a house in the United States to seek help for an alcohol problem, where are they most likely going? It is not to a psychiatrist, psychologist, social worker, treatment program, primary care doctor. It's to Alcoholics Anonymous. So it's very, very popular. Very, very popular does not necessarily mean effective. My grandmother took a pill, maybe you'll remember Carter's little liver pills. Lots of people took them. They were very popular, and the FDA ruled that they were inert. They were just sugar pills. They had no effect on the liver at all. And Carter's changed the name just to Carter's little pills, and people still took them. They had no effect, yet they were popular. So the fact that AA is very popular and millions of people are in it doesn't prove that it works. And some people in AA at some times have kind of been irritated, somewhat at scientists. Why are you even assessing that it works? We know it works. The reason we assess things is because when someone is holding themselves out to offer support for vulnerable people, it's a legitimate question whether or not it works. We have to ask, and we have. So to me, a landmark study in this field, actually, just going to back for a second and say, we had lots early on of correlation studies. So just very things like someone would show up in an AA meeting, a researcher, get people to fill out some questionnaires and show that people had been around longer, had longer sobriety. But that doesn't prove anything, right? It could be all the people who were doing badly dropped out. It could be a self-selection effect. So what changed in the last, now about 15 years, has been longitudinal studies with comparison groups and frequently with randomization. And I view this study of someone I'm proud to call my colleague, Christine Timko, as a landmark of this sort. I'm seeing some complaints about the audio. I'm going to try this. Okay, can Riley or Meg, can you tell me if you can hear me?
Yes, that's perfect.
Okay, so I hope that fixes the audio. Sometimes the headphones help, and I apologize for the sound was bad. I don't know why that happens, but it does sometimes. So what I was saying was that this is a study I regard as a landmark by Christine Timko. It was done at the hospital where I still have an office at the Menlo Park VA Medical Center. And here's how she cracked the challenge of how do you randomize to something that fundamentally is not something you control. It's not like a surgery you could withhold or a medication you could withhold. And what she did was she had 345 veterans who were in care for alcohol or illicit drug disorders. And she randomized them to a referral. So half of them got the usual referral, here's a list of AA meetings and community, you can go if you'd like. But the other half got a much more intensive referral. We had like a half-hour orientation. Here's what the groups are. Let me answer any concerns you have. Here's what would happen at your first meeting. And then a follow-up a bit later, another session where they say, okay, do you feel like you have a plan to get your first meeting? I would like to link you to an experienced member to get you to your first meeting. So it was you could think of it as a warm handoff, and that could be randomly assigned. And what she showed is, first off, that just that little intervention, not that big a deal, did in fact substantially increase people's involvement in 12-step groups, AA and Narcotics Anonymous and Cocaine's Anonymous, but also dramatic improvements on measured as the ASI, 60% greater improvement in outcomes in the intensive referral commission, much lower rates of drug use, much lower rates of alcohol use, just from that little randomized introduction to the fellowships. That's a pretty impressive finding, and also was the first really good randomized study of these groups, and it showed it was positive. And not the only one like that. Here's another one. It's first authored by Mark Litt, and also included other distinguished scholars in Connecticut. And this was a study of network support. So network support therapy, you try to connect people to activities and people which do not involve drinking. Now, it does not have to be AA at all. There's plenty of places like that. People might want to reconnect with, say, their church group or a baseball team or other kinds of activities. But anyway, they did monitor this, and they found that compared to case management, people randomized to a network support approach had dramatically higher involvement in AA and about 20% more abstaining days. And they followed them, I think, for 18 months. If I remember right, it might even been 3 years. But anyway, again, randomized results, which we hadn't had before. Thanks to support from NIAAA and then the VA, a number of these trials were done. And so eventually, some colleagues and I, Janet Blodgett, Todd Wagner, and I, decided to pull all of these data together from the various 6 different trials that had been done, including the 2 I just described. So we had over 2,300 people across 6 trials. And we used a statistical approach called instrumental variables modeling to estimate the proportion of the impact in these studies that was due to AA itself. And you do this, it's sort of complicated to explain, but the idea is that, some people in a control condition will go to AA anyway, but the people who get a randomized introduction or encouragement go more. And so you look at the difference between how much AA in those 2 conditions on the assumption that the higher part in the randomization group, the higher AA involvement is an effect that is exogenous because it was caused by randomization. And what we found anyway in those studies, this also include Project Match, was that AA came out effective in 5 of those 6 trials. The one trial that it didn't come out was the Project Match inpatient condition, probably because people in that study had already had a ton of AA, gone through treatment that was heavy AA oriented, and were still drinking a lot. So they were people who further AA was just not working for them. They needed something else. But the other 5 trials all showed a AA benefit free of selection bias. In other words, not due to the fact that people who are motivated are more likely to go, but in fact, a genuine effect of Alcoholics Anonymous. We subsequently tried to replicate this in the clinical trials network with a great team of scholars around the country. This was
They all donated their data. These were generally CTN studies, and tried to do the same thing except for drug use disorder patients. And we used the same method, pulled together all these clinical trials, sort of cleaned all the data, put it all into one big set of data we could analyze at once, and then use instrumental variables modeling. Now, the effects on this, there was good news and bad news on this. And I'll tell you what, the good news was, because these groups were largely founded by white men, there's always been some worry, or I've had some worry, that they wouldn't appeal to other people. But the good news was in this study, across all these diverse samples, that whether you were male or female, or no matter what race you were, your likelihood of participating in these groups was the same. There was no evidence of any disparity at all for any of the groups. However, it turned out that the randomized invitations, randomized referrals that had been used just did not work as well for drug groups. So the difference between somebody who got that structured introduction, their likelihood of going to AA or crystal methamphetamine anonymous, was not much higher. And that made us unable to use instrumental variables modeling, unfortunately, and also raises a clinical issue, which is it seems easier to get somebody to go to AA than it is to get somebody to go to NA. And we can talk in the questions and answers why you think that is. We didn't study it directly, but there's different ways we could speculate. But we did at least, we're able to do traditional regression modeling. And there are risks for bias here because it's not random, but nonetheless, it was positive in the sense that the people who were going more did in fact have significant lower rates of drug use, and interestingly of alcohol use as well. Quite a few people went to say CA and in combination with AA. And so they were doing better on both. But the demonstration here is not, I can't say quite as strongly about this as I could about the AA study because the randomized introductions didn't work quite as well for the drug groups. So now let's talk about money. It's something that occurred to me early on in my career when I was working with my mentor, the person who hired me, Rudy Moose, is if these groups in fact work, they really are a financial gift, right? Because they don't cost anything. I mean, people put like $1 or $2 in the basket, but compared to how much it costs to pay for a session of therapy, it seems like this should be economically advantageous. So we decided to look in the VA whether or not participation in these groups actually took a financial burden off the healthcare system. And we did that in a quasi-experimental study of the following form. We had over 1,700 VA patients. These were all male, that is a weakness. About half of them were African-American. We didn't have any women in this study. And they were receiving one of two types of care. 5 of them got care at VA programs that were heavily based on 12-step principles, put a lot of emphasis on self-help activities during treatment, really tried to encourage people to find a group and stay in a group after treatment. The other programs were very good programs. They were based on cognitive behavioral principles, what I was trained to do. It certainly works. But they didn't place much emphasis on self-help activities. These programs, this was not a randomized trial, but these 10 programs were scattered around the United States. I think the closest 2 were 500 miles apart. So people were quasi-assigned. People went to treatment close to where they lived. There are not many people who would drive 500 miles for cognitive behavioral therapy because they liked it so much more than 12 steps. So we thought it was reasonable to say, probably if there's differences between the conditions, they have to do with the treatment and not self-selection. We matched from a larger sample people on their prior utilization of mental health and substance use disorder care, which you can do in the VA data because we had complete information on all the care they'd used. So we had the people going into the 12-step oriented treatments and the non-12-step oriented treatments had the same amount of, like, if you add up the cost of all the mental health and substance use disorder care they'd used in the prior year, it was the same. We also looked if there were any differences between the conditions on things you think might shape prognosis, like social stability and comorbidity and all that, and there weren't any. So they were very similar groups of people. We followed people up personally to get their substance use outcomes, and then we used the VA databases for their outcomes of healthcare, which you could get 100% of. So even if we couldn't find somebody, we could still get an assessment of their healthcare utilization. So first off, it was striking, these programs were 21 to 28 day programs, that even a year later, the people who had been to the program that really pushed 12 steps, really pushed self-help groups, even a year later, showed higher rates of being involved in these groups. Definitely some people in the other programs did in fact go to groups, as people often do, but the rate was a lot lower. But did it make any difference? Here are the clinical outcomes. The 12-step treatment group is the orange bar, and the sort of greenish blue or teal, whatever that is the cognitive groups. So we measured 3 types of clinical outcomes. One was just abstinence, and this was a tough measure, perfect abstinence treatment. And the 12-step groups were significantly better on that. On the other 2, which were substance use related problems, things like substance use is causing problems in my marriage, in my work, with my school, whatever, they were the same. And they were also the same on a measure of positive mental health, which is basically the absence of any serious psychiatric or depression or anxiety kinds of problems. So you would say from this, well, the outcomes were a bit better and, similar in most things, but on straight abstinence, the 12-step treatment was better. But what were the cost implications? And this is where the really big differences come in, is that the amount of mental health care and substance use care used in the year after treatment was substantially higher among people who went into cognitive programs, thousands of dollars per person, more inpatient days, more outpatient days. This is an important finding, because normally in healthcare, if you spend less money, you get worse outcomes. But remember, the outcomes are as good or better, but they're being attained at a much lower price. What does that mean? How can that possibly be true? Well, I don't know for sure, but I'll tell you my guess. If you go into any doctor's office, any primary care office, you will see people in the waiting room who are sick and need to see a doctor. You also see people who are lonely, who just need to know someone cares, who need a pat on the back, who just want to talk, who are bored, need some encouragement, all very normal human needs that everybody has, including me. But you don't need an MD to meet those needs. So one possibility of what's going on here is that people who go through these programs, which really emphasize getting involved in a recovery association, go to their groups for those needs, for connection, for support, for a laugh, for a pat on the back, for a hold of the hand. And so therefore they're able, and again, psychiatrists, social workers can do all that, but you don't need that training to do it. And so what they're doing is they're kind of draining off surplus healthcare utilization, meeting needs that we all have, but you don't need a professional to fulfill. And that is great, because in the VA, as in every other care system, we're always asked to do more with less. And here's a way to do it. If we get people involved in these organizations, then that creates less demand on the system. They're doing better with their health, and that leaves more resources available for people who really do need to see a psychiatrist or a psychologist or a social worker. So we followed this study up at 2 years. I waited till I had tenure to do that. You should never replicate anything until you have tenure, because your cool finding can go away. It turned out that at 2 years, the same sample, the differences got even larger. So they were diverging in more and more self-help involvement in the self-help condition, and a bigger abstinence split. Again, this very tough measure of perfect 100% abstinence, but that difference was getting larger. And there was a further $3,600 healthcare cost reduction. So over the 2 years, about $10,600. That's in 2014 dollars. So we would update that now to maybe $12,000, $13,000, $14,000 per patient. And the VA treats over 100,000 patients a year. So if you multiply those numbers together, you realize that's an awful lot of money that 12-step groups are taking, a healthcare financial burden are taking off the healthcare system. And that's just the VA. It's just one small part of our system. So if you look at as a whole, this is really quite a gift to the country, that a voluntary association is doing so much to help people get better without financial demand on healthcare. So the most recent thing we've done, which has been led by John Kelly, who spoke on a different topic in this webinar, I think about a year ago, was a Cochrane review. So if you don't know Cochrane reviews, they are the most rigorous assessment that medicine does of what is known in a given area. And there had been a Cochrane review done in 2006 in AA. It wasn't candidly very good because there wasn't a lot of good research to review. So we got the band back together. Marika Ferry, who had worked on the first one, was willing to work on another one. John led it. And we thought, enough work has been done now, especially a lot of trials of both AA and then 12-step facilitation counseling. Let's try to pull this all together. And I say it's super rigorous. You have to even just submit how you're going to do the review. And that goes through all this intensive reviews, and it goes online before you can even start. And then we had, I can't remember how many peer reviewers of the process, at least 8, 9, 10 people very closely following what we did. In the study, we included randomized controlled trials, also quasi-randomized trials like that healthcare offset study I showed you. And we looked for studies that compared AA or 12-step facilitation to quality interventions like motivational enhancement therapy, cognitive behavioral therapy, which are very good therapies. We also looked mostly at clinical outcomes, but we did look where we could at healthcare cost outcomes. And we didn't look at coercion. We didn't look at people randomized in prison, but we did include, and we just focused on adults, not adolescents. And we, of course, included both men and women. You can read, this is all online and it's all free. You can read it or ignore it on your own time. But just to give you the gist of the slide, it's a very intensive process going through many databases with particular keywords. You get thousands and thousands of papers, and you have to cut them down by the way, in multiple languages. And you have to cut them down to those that actually meet the criteria that you've pre-specified. And those are what you review in your Cochrane review. Through that very rigorous process, which I think took almost a year just to pull all that together, we found 27 primary studies containing 10,565 participants. 21 were RCTs or quasi-RCTs, 5 were non-randomized, and 1 was purely economic. These were scattered across 36 reports. Sometimes people wrote more than one main paper on their finding. That's why there were 36 reports. These were done by different people in different cities or different countries. So the risk of any individual person's bias affecting this literature is very, very low. This is because these teams are working independently. In terms of outcomes, we looked at abstinence, which, as I mentioned, AA tries to instill. But we didn't just look at abstinence. We also looked at measures like drinking intensity. How many drinks per drinking day do you have when you drink? How many days, what percent of days do you heavily drink? What about consequences to your health, to your family, to your work, your severity of addiction, things like blackouts and sweats and shakes and so on, and economic analysis of whether there were healthcare cost offsets. And the biggest difference was in abstinence, and it was a very, very large difference. The blue line here are the 12-step facilitation AA kinds of conditions. And then the comparative treatments are generally, as I said, motivational enhancement therapy or cognitive behavioral treatments, mostly comparisons. And this is the, complete abstinence. So absolutely perfect, not a single day of drinking. You can see those blue lines are a lot higher. Sometimes twice as much or half again as much. If this were a cancer study, everyone in the world would be kicking down the door to get the blue, whatever that thing is in the blue line. This is a huge difference. But it was not just about abstinence, even though AA does focus on abstinence and does incredibly well at abstinence. One of the very interesting findings was if you skipped over abstinence, it looked at things like, of people who kept drinking, did they drink less? Or did they have fewer heavy drinking days? And AA also worked for that about as well as these other treatments, sometimes a little better, but about as well. So it is not the case that, all it is abstinence, and if you don't abstain, you're a wreck. Not true. Quite a few people cut their drinking from AA, but keep on drinking, contrary to what the organization says and what a lot of people believe. So it really is not a one-trick pony. It works across a range of outcomes. We also looked at the healthcare cost studies. Other studies have replicated those findings that I showed you of it reliably produces reductions in healthcare costs when people get involved in AA. We also looked at mediational analyses, and I'll talk a little bit more about that. In other words, how it is that these treatments work. But one of the key findings was, why does 12-step facilitation work, 12-step facilitation counseling? And the big reason is that it increases participation in AA. So AA is part of the mechanism by which 12-step facilitation counseling works. So now let's get into mediator. What do we mean by mediator? So if you see people going into a treatment program and coming out better off, A mediator is, well, what happened in there? What is the link in the causal chain? We go A to B to C, what's the B? So we know people go to these groups and then later on they're doing well, but what's changing along the way? They can't go instantly into wellness. So what is the factor that's driving it? And here's one study our group did to look at this. This is a structural equation model. And normally I used to put this up with a bunch of gamma and delta weights, and basically half the audience fell asleep and the other half started updating their Facebook page. So I took all that out, but if you want to read all that statistical detail, the reference is there at the bottom. This was published in Annals of Behavioral Medicine. But we follow people over at the beginning of their involvement in self-help groups, and then 1 year and 2 years later. And at the end, we saw at 2 years, they were using a lot less substances, but we tested what along the way changed. And there were multiple things. There was coping, active coping. So they were more likely to say when confronted with a problem, not necessarily an addiction problem, any problem, endorsing strategies like, well, I made a plan of action. I asked a friend for advice. I tried to get more information versus avoidant coping. Like, well, I pretended the problem wasn't there. I just tried not to think about it. I pounded my fist on the table. So they become better at coping in general. The motivation to change greatly increases. Something that's said about AA and NA and CI that is unfair is only motivated people go there. That's wrong. In fact, quite a few people go there kicking and screaming. You know, they're being nagged by their spouse or their boss. And so they're going to go to this one stupid meeting with the stupid people. And then they hear a story that catches their interest, or they meet somebody they kind of like and thought, okay, I'll give this stupid organization another chance and another chance. And then they start going. It's motivating. So people actually are more interested in recovery the more meetings they go to. It actually has that effect rather than it being, as sometimes people think, the other way around. Motivated people go to a lot of meetings. It's going to meetings is motivating. We also saw two changes in friendship quality. One was general friendship quality and just, unrelated to addiction. If you just ask people, do you have people you trust? People care about you in your life? They're more likely to say yes. But then if you ask specifically about friends who supported your abstinence, so people who would give you specific support to help you stop drinking and would, for example, not offer you alcohol, that also went up. So all those things change along the way to a person reducing their substance use in these groups. These are only, that's what our group found. Other groups have studied this and found other important things. One is an increased self-efficacy. So that's, I can do this. I believe I can recover. Commitment to abstinence. I mentioned motivation. So it's not just I can do this, but I want to. Other groups have found improvements in coping and social supports like we have. There's also been some work, for example, by Sarah Zemore showing that spiritual and altruistic behavior, helping other people or having a spiritual awakening, as Leanne Cascuda showed, seemed to help people stay in recovery. And then the replacement of substance using friends with abstinent friends. I'm sure a lot of you are involved in treatment and you know that challenge of the fact that many people, everyone they hang around with uses lots of substances. And so, it's tough for them to recover. Where do you find people who you can hang around with? Well, for a lot of people, it's in the recovery fellowships, and they swap out people who drink and use drugs with those who don't. And this slide shows that effect. We divided up the people who had a 12-step friendship network, very connected to 12-step, and those not. And it was interesting, there was quite a split in the data. You can see on the left side, when we asked people to enumerate their friends, about half the sample said that 90% of people they were hanging around with were other 12-step people. This is in the year after inpatient treatment. And the other group had virtually no friends in those groups. And that then translated to much higher rates of abstinence in people who had 12-step friends. And this is a phenomenon, by the way. It is not unusual to see in early recovery after treatment, people are intensively engaged with 12-step, other people in 12-step, to the point that sometimes even their families resent it. Like I remember someone saying, well, he used to always be at the bar, now he's always at AA, what's the difference? But this tends not to last. This is kind of like a caterpillar turning into a butterfly. There's that intensive engagement in the first year. It really has to be because it's so hard to make that initial change. But over time, people tend to engage with other friends, re-engage with their families and other things. But at least in the short term, it's like a cocoon, and it's good for people. It's a protective bubble of friends who are also in recovery. So that's a lot of science. Who cares? What difference does it make to you if you're practicing, or what difference does it make if you're setting policy? So a couple things about that. One is we can do a lot to help people get into these fellowships. It's not a case that it's just, well, those who it works for will go and those who don't like it won't. But we have some really good studies of that sort. Here's one. This is by Leanne Kaskudis, and it was done, I believe, in Oakland, but I know it was with social model residential programs. And this is a quasi-experimental study, and she developed a course called Making Alcoholics Anonymous Easier, or MAZE, which was a mixture of psychoeducation, chance for people to talk about, what groups they might go to or any experiences they'd already had, making strategies to participate, how to get the most out of it. And just by doing that program, they basically doubled the rate of abstinence 12 months later, both for alcohol and for other drugs. And so that's a really big effect. Who wouldn't like to double the rate of abstinence among their patients? So that's pretty impressive. The biggest barrier I find when I give this talk to people is them saying, oh yeah, we do that already. We already get people into these groups. And I say, what do you do? Well, we hand them a brochure and say, there's these groups. You could go if you want to. And so I just want to show you a study of that. This is a very badly designed study. It had only 20 people in it in a randomized trial for behavioral intervention. So you would normally say that you never have statistical power to find anything with 20 people. But here's what they did. They had people who were in alcohol outpatient care, and half of them were randomized to probably the standard of practice in the United States. Here's a brochure. There's some meetings out there. If you want to go ahead. But the other 10 were randomized in the intensive referral to the therapist saying, and by the way, I would like, with your permission, to call an experienced member on the phone to take you to your first meeting, and I'll put you on the phone with them. Despite this very silly, low power trial, shows what I know, they found something anyway. If you got that extra intensive referral, your likelihood of making it to a meeting was 100%. And if you got the brochure, your likelihood was 0. The difference between 0 and 100% is what we scientists call big. That is a very big difference, and it is statistically significant, despite the only 20 people there. So good on them for agreeing to do this. But it's important to remember the serious point is that the standard referral is actually what most happens in our treatment system. We don't do that extra warm handoff, and we really should, because it would make a massive difference. I like to emphasize as well that, addiction is not just about mental health settings or addiction settings. There's other places where we can be helpful, getting people connected to recovery fellowships. This is a study by Rick Blondell, who's an ER doc. This was done in a hospital where people came in due to an alcohol-related injury. So they, in their mind, they are not there for an alcohol reason. They're there because they broke their leg in a car accident or something like that. So they're just in the hospital. And one group gets the standard of care in America when that happens, which is nothing. People just don't talk about the alcohol and just sort of pretend, yeah, it's too bad you had an accident. The second group got a brief intervention. A nice, good, doc comes in, does the whole, 15 to 30-minute wrap. You all know what that is, motivational enhancement stuff. And then the third group gets that, and they get a peer, someone who comes in who's in recovery and says, hey, you know what, I was in your situation, and I really benefited from these fellowships. And if you ever want to go, here's what they're like, and they might help you. So you can see the effects there. So 6 months later, in terms of absence, the control condition, about over a third are abstaining, probably because the accident scared the life out of them. Very few of them go to treatment. When you add the doc during the brief intervention, it really helps. You get 15 extra points on the abstinence scale there, and a higher treatment initiation rate. But then that peer on top really takes it to a new level. Almost 2/3 of people abstinent 6 months later, and about half initiating treatment or Alcoholics Anonymous. So, and this is outside of psychiatry. And this shows what we have to give to the rest of the healthcare system and why we need to push recovery everywhere, not just in mental health and addiction clinics, but also in general medical settings. Now, what about non-12-step mutual help organizations? I presented lots and lots of data about these groups. I've certainly referred patients to them. I've referred friends to them. I do believe in them, but they're not for everybody. And sometimes when I've talked about them, people say, but I know someone who had a bad outcome in 12-step groups. I do too. Nothing works for everybody, nothing. But they do help a lot of people, but there should be alternatives. And there are, thankfully, more non-12-step groups. And that's good because people are diverse. The 12-step groups don't have as long a history, and they're not as big, so they can be a bit harder to find, but they do exist. Most of the research on this has been descriptive. I mentioned my friend Leanne Kaskudis. She did her dissertation on women for sobriety, which is sort of a a feminist take on recovery. Instead of 12 steps, there's 14 affirmations, and AA has a lot of emphasis on humility. And, the woman who founded Women's Sobriety felt that, basically society tells women, the women don't need to work on their humility because society is so prejudiced against them. She actually focused on building a sense of worth, building self-esteem, and in an all-women setting. But anyway, that's one group that's available. Another one, my colleagues and I studied, called Moderation Management. That group is based pretty closely on cognitive behavioral principles. And unlike the others, is really aiming for less severe drinkers and trying to teach them to drink in a healthy fashion again. So it's not an abstinence group, but there is a population of people who that's very helpful for. And our study of that group, by the way, showed is mainly college-educated people, higher social capital people, who you would think generally are more likely to be able to succeed in a moderation drinking goal. So that's another option that exists in some parts of the country. And also these groups now all exist online. Sarah has gone on, Sarah Zimor, who was a mentee of Lee and a colleague of Lee, and done some really nice stuff with starting to look at longitudinal work with Women for Sobriety, as well as some other groups, Life Ring, Secular Sobriety, which is takes out some of the spiritual stuff, Smart Recovery, which is a cognitive behavioral oriented group, again, without the spiritual components, as science is the ultimate authority, but showing some initial evidence that these groups are also effective, even though there's not as much research. What we have is pretty encouraging. And then John Kelly, who I mentioned led the Cochrane review, has also now got a new grant to study smart recovery, and he's going to characterize professional and non-professional recovery support participation choices and how people switch between pathways by following about 350 people over a 2-year period who are making their first recovery attempt from alcohol use disorder. And one of those options is going to be those pursuing smart recovery and whether they do better or worse than people not pursuing that outcome. And then also going to study whether the mediators of change are similar, like self-efficacy or impulsivity, and whether they're moderators of things like gender and psychiatric comorbidity and so on. So, it's great that Sarah and John are pursuing this, and I hope we have more research like that because, it's good to have options, but we want to check them all out, right? Because just because something's different than the known doesn't mean necessarily works. So we still want to do these kinds of evaluations and make sure that these are good options for us to refer patients to. Just before ending, I just want to mention that we can also do things beyond the level of the patient at the policy level to kind of help self-help organizations grow. So this is a project I worked on. I did a sabbatical in Newcastle, which is in northern England, and was working with Nick Heather, the psychologist. And we got some money from the Department of Health and worked with Alcohol Concern, which is a charity, and Smart Recovery UK to try to expand access to SMART in that country. And what we did there is we developed a training program and local champions who would speak up for SMART in various treatment agencies. And that could be both running groups, but also telling their colleagues about them, facilitating people's access to them, encouraging people to run them by themselves. And, it was not much money. I don't remember what it was. It was pretty modest investment, these champions around, but it established 18 groups in 4 different regions of England. And one thing I was particularly happy about is of those 18 groups, we actually didn't start a third of them. What happened was people would start meeting. In fact, some of the ones we helped start fell apart, but then people would say, you and I are both driving 45 minutes to get to Sheffield for this group. Why don't we found a group where we are? And then they would start their own. And that's the perfect thing, right? Because you don't want these to be run through research grants or by professionals. That's what would kill the magic of them, is their grassroots nature. But, you can support people getting going to the point that they can run them themselves. And that's an exciting method. And, smart recovery fits in some ways for a certain. England is a more secular country in the United States. It's kind of a good cultural fit for them. They also have AA, of course, but there's a lot of people in England who liked SMART, sort of felt it resonated with them as a way to deal with their alcohol or other drug problems. And this was a very inexpensive way to bring that resource to more people. And it also was effective in just having more professionals know what SMART is so that they could refer patients to it. So I'm going to, this will be my final slide, and then we will have time to take your questions and answers. I just want to summarize my points. Okay, so the first one is that 12-step group participation, particularly Alcoholics Anonymous, but any of them, significantly reduces substance use and healthcare costs. And I want to be clear, I don't mean it's correlated with or associated with, I mean cause. We now have, as I showed you, lots of randomized, quasi-randomized studies. We have a Cochrane review. It is causal to say AA causes people to drink less. It causes reduced healthcare costs. It deserves to be thought of as an evidence-based intervention right alongside the procedures I was trained in, and I expect many of you were, cognitive behavioral therapy and motivational enhancement therapy. There's still some bias against AA among professionals because it's non-professional or they don't like the spiritual stuff, but just as a matter of science, AA is as good or better as what we do. Why do these effects exist? Well, we know that they are mediated both by psychological changes and social changes. It's important to remember how groups are different than therapy. I care about, when I was doing therapy, I of course cared about my patients, but I couldn't become their friend or spend my whole life hanging around with them. But that does in fact happen in these 12-step groups. So you get the change processes you see in therapy, like greater self-efficacy, greater confidence, greater motivation, that kind of thing. But you also get new friendship networks, which are nurturant of recovery, which is very hard for us to provide as professionals. And both those things are important, along with other things like opportunities to help, spiritual change, altruism, in getting people into recovery. 12-step groups are not everything. They are great, but they're not for everyone. There's some people just not going to work for, and no one should be browbeaten or shamed because it didn't work for them. There should be alternatives. And there are, and now we are studying them, and that is really good. And also, of course, there's some people who won't like any group at all, and that's okay too. The point is recovery, and there are many pathways to get there. There's not one right way to recover. It just happens that 12-step is a very good one, but there are others, and there always should be. Last, just to emphasize that pretty modest investments can really increase the impact of these groups on public health. Sometimes that modest investment is just us saying, rather than just handing you a brochure, would you like to meet somebody who's in these groups and help you over that threshold to that first scary meeting where you have to walk into a room and there's people you don't know, or you're not even sure where it is, and you need to get over that anxiety from that, or someone to ride the bus with you, or are we willing to invest a little in champions, like we did in the Smart Recovery Project in the UK, where groups allow that, where we put a little money into education, help things get started. Eventually they'll run themselves, but we give it that boost. And it really is, not a lot of resource investment to build this up. And I think it more than pays for itself, both in terms of just in strict financially, as I've pointed out, you reduce healthcare costs, but also just in benefiting public health. It's not a lot of effort to really increase the number of people who find recovery, which of course makes their lives better, their families' lives better, and community life better. So I'm going to stop there. Thank you for your attention. And Riley is managing the chat box, so I'm going to turn it over to her.
Perfect. Thank you so much, Dr. Humphreys, for such a wonderful, informative talk. We really appreciate it. So we have a couple questions here. The first one is, does the research change the original position that AA takes and make it more scientific as opposed to people-oriented?
AA itself was always interested in some kind of professional blessing. Wilson wrote to Carl Jung, I think, gave a presentation at the American Psychiatric Association, and wanted doctors to have a positive view of it. But they really didn't have much understanding of how the scientific evaluation studies worked, nor were they particularly motivated to conduct them, because their purpose was to produce sobriety. They felt they were. So it was really the arrival of scientists, and also, frankly, the creation of things like NIAAA and NIDA that brought that scientific point of view to AA. And they do embrace this now. I mean, they are, they do not affiliate with outside organizations and all that, but they are very much aware of the research. And they know I've met people who are like trustees. They know about the evidence that what they was beneficial. And so I think that's been a good, useful thing for them. It's something I would say is sort of, to me, I thought was kind of moving, actually. is when we did the Cochrane review, New York Times covered it. And first off, it was one of the most read things that the New York Times Upshot section had ever published on any topic. It stayed up there day after day after day under the most read and most emailed and most commented upon piece. But second, if you just look at the comments, there's like 1,000 comments on it. And a lot of them are people saying, I have been made fun of for years for going to this group, and it's such a relief to know that this is scientifically based, and I can tell people to back off. Or I work at an agency and I feel diminished because I refer clients to AA, and other people say, oh, that's unprofessional, that's old school. It was very validating to know, no, actually, the best science we can do says what you're doing works. And that, I think, that made me happy as a scientist, that it gave people a sense of legitimacy, which they deserve because they are saving lives.
Perfect. Thank you so much. We're going to go on to the next question here. I do want to just remind everybody, if you have a question, go ahead and please put it in the chat now so that I can get to those and ask the questions to Dr. Humphreys. So the next question is, where might MARA, Medication Assisted Recovery Anonymous, fit in this recovery support landscape?
So is that, I don't know if that's different than MARS, if they've renamed themselves, the Walter Ginter's organization, but those have been important. I don't, the fellowships that allow people to take medications are important. Historically, AA was pretty hostile to things like antidepressants even. That's kind of gone away, but you certainly see in NA some quite negative views about, say, methadone or buprenorphine. Although in fairness, you also see negative views about methadone and buprenorphine everywhere. I mean, doctors are negative about them too. But so that can be a barrier for people. And I think it's important with patients to reassure them of the value of their medication. And also, if they have a member who thinks they're a doctor, is to give them the pamphlet AA has. It's called something like AA in Medicine or AA in Doctors, which says flat out to AA members, do not go around telling people, don't give medical advice as an AA member. You should not be doing that. That can be a challenge. I tell you, though, one interesting thing, there's now multiple studies of people who are on buprenorphine, and the ones who go to 12-step groups have better outcomes than those who don't go. So clearly, people do find a way to mix and match elements that may seem opposed and get them to work for them. And I find that kind of encouraging.
Okay, thank you. So next question. Most of these studies focus on AUD. What is the most compelling data for NA for OUD?
Yeah, that's good. And as I mentioned, the AA evidence is stronger. So you can look at let's see if I can still, do I have control here or not? I'm not sure. Yeah, I do. If you go look at the study we did, and I'm just taking a second to get back here. Here we go. So this is published in Drug and Alcohol Dependence. You can see the title and the authors there, and I think you all can get these slides. If you don't get them, you're welcome to have them. I would look there at the source studies of all these, because these are all studies of CA, NA, and so on. But the data weren't quite as strong, honestly. Overall, there's also a big review that William White did that you can find on William White papers that I helped him with, and John Kelly and Mark Galanter did. There's a lot of, all the facts are friendly for like NA and CA, including for opioid use disorder, but it's been harder to do randomized studies, and so they're not quite as strong. It may, and one thing I think fundamentally, it may be harder to get over illicit drug disorders than alcohol. And it may mean that people need more. That's certainly possible. Or it could be that illicit drug use disorders correlate more with other things that make life harder, whether those are structures that are set against people in society or other illnesses. And that may be why we didn't get quite as strong evidence for NACA as we did for AA.
Okay, the next question. How would we invest in AA infrastructure? Funding for AA must come from within the organization.
Right. We would train our staff to do, for example, what those people did in the AA program, the treatment programs that were really good at getting people into AA. We would invest money in running Leanne Kaskudis's MAZE course in residential programs. We would teach people how to do a warm handoff. We would have people, emergency room doctors like copy Rick Blundell and make a friendship with a local fellowship that we could come in and visit patients. None of those things are about writing a check to AA. They're actually about improving healthcare, making investments in healthcare that ends up getting more people into AA, getting more people into recovery. But you don't violate the tradition that AA has, which is a noble one, that, you know, they're not for sale. But this is about us spending our own resources to make ourselves better at connecting patients to the fellowships.
Right, thank you. So next question is there any research on the efficacy of dual diagnosis groups / AA for people coping with dual disorders?
So there's quite a few people in almost all these studies that have dual diagnoses, who have psychiatric, and the facts, as you see, are pretty friendly. I mean, people do seem to do well, even people who have, say, comorbid depression, anxiety, or sometimes SMI. There's also work by Alexandra Laudet, which is spelled Laudet, on dual I can't think. I'm afraid my aging brain is, the name is something like dual disorders recovery or something like that. But anyway, I do know it is Alexandra Laudet, who studied groups specifically with that purpose, and you can take a look at that and get a sense of how well those work. Those were studies done, quite large studies done in New York mainly, I think.
All right, thank you. So do you have any resources to best train health professionals to do a better 12-step facilitation?
I mean, there's a number of useful things available. I mean, NIAAA for free will give anyone who wants them a 12-step facilitation handbook. I mean, they published that, and it's a very nice book. Joe Nowinski was, I think, the lead author of it, or at least one of the lead authors. That's there for anyone who wants it. Part of this also is just the basic human willingness to do the simple thing of, like, you know, calling your AA line, or maybe going to an open meeting and saying, hey, you know, I work at the hospital, and if there's people who are interested in coming in, volunteering, meeting people as they're leaving, please, let's have coffee together. And that part of it is just not so much a cognitive kind of learning, but just a willingness to connect with other people connected in the community. So those are two resources. You can also get Lee's MAZE, I'm pretty sure is available for free online, or it might be free from NIAAA, because that was developed with an NIAAA grant, but that's another useful tool. Or Chris Timko's warm handoff tools, I know, are also available freely. So any of those things could be used.
Perfect, thank you. So on to our next question. Did you study outcomes when treatment settings offered 12-step meetings for patients on site? And do patients transition to outside 12-step meetings in this scenario?
Good question. So in the big VA study with the 1,700 patients that really were looking at the 12-step programs, all those 12-step programs had meetings on site, as well as encouraging people to attend meetings in the community. And, you know, on site is a good opportunity to introduce people to the fellowship, get them comfortable with it. But of course, in the end, they're going to leave treatment, you know, and probably not going to come back to the hospital-based group. So that's why it's important to also be connecting them with groups they can attend on their own in the community. I mean, both, I think those things add to each other. And if I remember right, people who went to more meetings during treatment were more likely to go to meetings after treatment.
Okay, so this one says, comment on this, ? It's important to acknowledge alternative / non-12s because, as was noted, no single treatment works for everybody, and absence of evidence does not mean evidence of absence of value. Treatment pros really ought to be acquainted with other organizations.
Yeah, absolutely. As I said, there's many pathways to recovery. Absence of evidence doesn't mean evidence of absence. Of course, absence of evidence doesn't mean proof of evidence either. Sometimes evidence is absent because people found it and there isn't any. But we shouldn't assume that, say, you know, secular organization for sobriety does work or doesn't work if we haven't studied it. And we should definitely be giving people lots of choices. Choice is good for people in general, and people are more likely to participate in something where they feel they've had some input. And there's a lot of there's a lot of sorting even within. Even if you're going to refer somebody to AA, there's a lot of variety within AA, and people are going to have to do something sort of like dating. You have to find a place that fits for you. And I'm also impressed at the number of people who mix things. So, Women for Sobriety, set up by Jean Kirkpatrick, not the UN ambassador, a different Jean Kirkpatrick, but she really felt it was very, very different than AA, opposed to AA, and yet a lot of members go to Women for Sobriety and AA, and they sort of sort these things out. And that's a process we should all be open to, rather than saying you must do this thing or you must do only one thing. What we want is people to get better, and there's lots of ways to get there.
Okay, thank you. So our next question. Several times a week convening life-ring secular recovery meetings, I still hear how 12-step meetings make people feel powerless. Are you saying that is just the difference in people?
At least part of what all the alternatives spend at least some time doing, and I know from people who work in them, feel ambivalent about doing, is complaining about AA. So that they do get a lot of people who went in AA and didn't like it. And I've heard smart recovery facilitators say, like, to try to redirect conversation times, let's not engage in AA bashing, let's engage on our own recovery. And so, if you feel bullied into doing it and it doesn't work, it's understandable. You might feel resentful of it. And within those alternative groups, there are people who feel that way. It's understandable. Although in the end, of course, complaining about AA will not get you into recovery. So I think to the extent they develop norms of let's not AA bash, let's not talk about what's bad about where we aren't attending. Let's talk about what's good about where we are together and now, and how we can use that to help ourselves.
Okay, thank you. So the next one is a multiple part question here. The first one is how successful are individuals with the White Buffalo / Wellbriety group?
That's a good question. I am not expert in that area at all. Don Corius, who's a remarkable person, and Bill White, who's also a remarkable person, have written a lot about that. And it's available, what they've written is on Bill's site, which is just William White Papers, all one word. It's a really beautiful site. But you could look at that, Don and Bill's writings about that organization, and also more generally about the long indigenous traditions around recovery organizations, which is a very fascinating one in itself.
Okay, the other question to this is, have you heard of the Sober Faction?
I have not. I don't know what that is.
Okay, and then it goes on to say, one of my clients has issues with the GOD word and asks about these. SMART, refuge recovery, any research or input about these programs?
I don't know refuge recovery, but SMART recovery says our ultimate authority is science and does not mention spirituality or God in any of its materials, to my knowledge. As a practical matter, plenty of people end up talking about spiritual issues in almost every recovery association, even if they don't, if the organization doesn't mention it, because they're often dealing about things like life and death issues and basic questions of values, so that's not unusual for people to talk about that. But SMART really, if someone really if they hear the word God, they flip out, I'd say SMART might be a really good place for them, because they are very unlikely to hear it at a SMART meeting. I think that's also true of moderation management. If it's someone who's seeking to become a moderate drinker again, they also, although some people talk about spirituality there, they don't mention God in their steps.
Okay, so the next question is, can you please comment on the virtual meeting efficacy?
I have been watching this unfold, I know a lot of people in recovery, obviously, at this point. So I'm looking at it from the outside, but I listen to what people say. And what I would say is that during COVID, for people who had been in a group a long time, the transition to Zoom has gone mostly okay. I mean, if you've been meeting at a group five years or whatever, and you have some online meetings, and at some point this will past this rotten illness and go back face to face. They seem to be okay. I'm not sure it's equal though for people who are new, you know, because you can get lost on the screen with a lot of faces. You don't get a hug. You don't have anyone sort of leaning in close, or you can't have those little informal, that are often so important, informal chats before the meeting of just someone saying, hey, you know, how are you? Check in. You want to go get a cup of coffee, that kind of thing. So I kind of worry about that. The person who is just seeking recovery for the first time and what is available is a Zoom meeting. There's nothing we can do about it right now, right? Because of, you know, COVID. But my guess is, and it is an unscientific guess entirely based on listening to other people tell me about it, that it's a bit worse. And so I hope we will have a more normal life, you know, coming soon. And one reason I hope for that, among many, is that I think that will make it easier for people to connect with these fellowships.
Thank you, Dr. Humphreys. So that's all the questions that we have today. We would like to sincerely thank you for the wonderful talk that you gave us with all the information.
Thank you.
And everybody have a wonderful afternoon.